Welcome to part 3 on pelvic disorders. This is the last section. We're going to talk about uterine fibroids, a very common condition in women affecting 1 in 5. That's quite a bit. So 20% of women are walking around with big old fibroids. But what these are benign muscle tumors that affect the myometrium itself, which is the body of the uterus. Now, I say benign because 99.9% of them are benign, but every once in a while we'll get one that will become malignant. This is a very common phenomenon in African American women. There are other names for the same condition. We call them leiomyomas and myomas. They all mean the same thing, fibroids. Look at these fibroids in this uterus. So the picture on the left shows you the various areas where fibroids can develop. They can be in the muscle itself. The one on the very top is a pedunculated fibroid. And when you see that, a problem with it is it's heavy. It can twist on itself and become necrotic and cause excruciating pelvic pain. We can have subserosal fibroids. We can have a pedunculated fibroid that's affecting the submucosa within the uterus, so it's hanging inside. What do you think is going to happen when somebody's trying to get pregnant? This fibroid is sitting in there, and it's impossible for that ovum to implant. We can have a submucosal fibroid. We can have a fibroid that's affecting the cervix. In fact, we had a patient at St. Joe's last week who had to have a C-section because her fibroid was in the cervix and it blocked the os from being able to dilate. When you look on the picture on the top right, this just shows you what they're looking at when they go in to do the hysterectomy or the myomectomy. They're very vascular. They can be slow growing or fast growing, and you can have many, many fibroids. It's amazing to me when I am examining a patient and I'm doing their belly exam and they either don't know they have a fibroid or I'm expecting to feel just a normal flat belly, and I have this hard mass, and I'll look at them like, what the heck is this? Oh yeah, I forgot to tell you I have fibroids. And I'm palpating a uterus that is a 28-week size, as if she was pregnant. And the bottom picture is one at the time of hysterectomy. I believe they said this weighed 7 pounds. I think it's 3.4 kilos, but it's hard to read what it says. So what are the signs and symptoms of fibroids? Well, the biggest thing is bleeding, and it's bleeding between periods and very heavy menses, and they have a lot of cramping, and sometimes they have clots. So I had a patient yesterday who does have fibroids. She was changing heavy-duty tampons and pads every 45 minutes for the entire day. So she needs to do something about those fibroids. And they can have periods that last longer than normal. They can have frequency of urination because depending where the fibroids are, it can be compressing forward onto the bladder. And so they feel like they have to urinate a lot. So I already discussed pelvic pain. They'll have pressure and fullness in the lower abdomen, and then they can have pain with intercourse. So for our diagnostic evaluation, most of the time we can feel these during a bimanual exam, during the pelvic exam. Fibroids are very hot, not hot, they're hard. They're very characteristic feeling. They feel to me like a baseball. So, they feel like a baseball as far as the firmness. We can see them on ultrasound, and I put this picture in on the right because here we have a very large fibroid that's on the left, and right next to it is a developing fetus. The uterus, it's going to get enlarged, but fibroids grow with estrogen stimulation. And so this is a high-risk pregnancy because as this uterus is getting bigger and bigger, these fibroids can get bigger. Sometimes they are, as they're growing bigger and they're so vascular, they have a lot of vasculature to them, and they can be compressed and then they become necrotic because they've lost their blood flow. This is also going to cause uterine cramping, pain, and it may cause contractions. So we really watch these ladies who have fibroids. We can do a hysteroscopy because if they're having difficulty with conceiving or the uterus is enlarged, we see it on ultrasound, they'll take a look in there and see how big it is. And if it's a pedunculated one, they can go ahead and remove it. And then, of course, we have laparoscopy to look and see what they can find. So the management of fibroids is multifold. We like to use the wait and watch approach, especially if this woman still desires fertility. We can put them on birth control pills to help control their menses. So the fibroids may or may not grow. Usually they don't grow with birth control pills because the estrogen content is so low, but we're definitely going to minimize their periods. We can give them a progesterone wrapped IUD, and that reduces the pain that they have with their periods and decreases the bleeding. Many of these women are very anemic. I've had them walk into the office with a hemoglobin of 8, and it's all related to their periods. And so if it's 8 and they don't have any iron stores, so their ferritins are below normal and all of their iron studies are below normal, we will refer them to hematology for an iron infusion. Otherwise, we're going to give them ferrous sulfate, ferrous fumarate, any of the over-the-counter irons, and they need to take it 2 to 3 times a day based on their hemoglobin. So you need to do your education about how to take it, what to take it with. Some say taking it with 250 milligrams of vitamin C helps absorption, and you definitely don't want to take it with any kind of calcium products. You want to separate that by 2 hours. We like to have them use nonsteroidal anti-inflammatory medications that are over the counter, and it helps with the pain, it helps with cramping, and believe it or not, because of the prostaglandin inhibition, it minimizes the bleeding. It doesn't make it so they have no bleeding, but it decreases some of the flow. We can also give them Depo-Provera, that's what DMPA is, and that reduces the growth potential because this is progesterone only, and so there's no estrogen influence on the growth. And then we're going to monitor the growth of these fibroids. And if they are very fast growing and they're multiple, then they may need surgical correction. So you can see on this picture, that's a pretty good sized fibroid that's growing and encroaching on the endometrium. So the surgical management is going to depend on the age, the fertility desire of the lady, and the symptoms. So the most conservative approach is doing the myomectomy, where they're going to go into the muscle layer and they're going to remove the fibroid itself. And I had a friend who had 11 fibroids removed through myomectomy, and she still wanted to have children. And so part of the education when they're going to undergo a myomectomy and have the potential to have children in the future is, number one, they're a high-risk pregnancy because we have breached the muscle wall of the uterus, and we worry about uterine rupture as the uterus grows. And number two, this woman is not going to be allowed to go into labor. She has to have a cesarean section for the very same reason. We fear uterine rupture. We can do a hysterectomy if the woman is in her 40s, not staring at menopause in any way, shape, or form, but very symptomatic and no longer desires children. And then another thing that they're doing is more of a conservative management and would be really good for people who are high risk for going under anesthesia is embolizing the uterine artery, which supplies the blood flow to the myometrium. And so what they'll do is an interventional radiology, pass a catheter, and then they get right up next to the bed, the vascular bed of where this fibroid is, and they embolize it. Now, if a woman has many, many fibroids, they're not going to direct it. This isn't the approach. This is going to be one who she has 1 or 2, and we can go ahead and just embolize it so we decrease the flow. This ends the lecture on pelvic disorders in women. Thanks for listening.